Dr. Krishna Shankar. Senior consultant in diabetes, thyroid and endocrinology, Sri Ramakrishna Hospital. Dr. B. Shobi Anandhi, consultant pediatrician and pediatric endocrinologist, Sri Ramakrishna Hospital. Our marketing manager, consultant, and our beloved postgraduates and my dear students from Allied Health Sciences Institute. First of all, I thank all the students for coming here. On a holiday, disturbing their sleep.
As the meeting started, audio's not there.
Good evening, doctor. A small problem in internet connection.
Okay.
Another few minutes, it will get started, sir. Thank you. Sorry for inconvenience.
Thank you.
மற்றவங்க பிபிடி தெரியுது. வேற ஸ்கிரிப்ட் தெரியல. So, good evening, everyone. I'm audible. So, good evening, everyone. So, for access in the I thank management and the trustees for giving me this opportunity, ever encouraging academics in our institution, as well as for the doctors outside and periphery also. And I also thank deans for being constant support for us. So today's topic is about diabetes. Since it's diabetes, specific diabetes. So each and every day, health, be it doctors and allied, maybe feel they may have coming the model to solve the right. If you November 15, develop in is it
Not audible.
over diabetes? Three thing diabetes and easy solve in uh, diabetes. Every thing, it's a challenge. The initial might be 3 months, so we learn in a the color uh, and it will be a few days we came across in a
can't use பரவாயில்ல. அது உங்களுக்கு தெரியுங்களா? கேட்டு பாருங்க. மேடம் உங்களுக்கு தெரியுதா? தெரியுதுல்ல? சரி, ஓகே.
Audio is very poor, not able to hear anything. I don't know about others.
எல்லாத்துக்கும் சொல்றேன். ஆனா எல்லாத்துக்கும் லாகின் ஆயிருக்கா?
லாகின் இருக்காங்க. ஆனால் நெட் வரல, இன்டர்நெட் வர மாட்டேங்குது. இப்போ அந்த இப்போ வந்து சேருங்க.
இப்பங்க அவ்வளோ ஸ்லோ ஆகுது. சரி, 50-year-old, 20 years of diabetes, cachexia with coronary disease and PDCA, recurrent urosepsis, chronic UTI with the proximal myopathy with proliferative diabetic retinopathy. So this is such a presentation. This is particularly important for postgraduates. So this is how you can elaborately see all the florid complications of diabetes mellitus in almost all the individuals who are admitted in the hospital. This is one such case. You might be seeing only the glucose value. We won't realize how long it's going on. So this individual is literally, if you just leave them before untreated, it might be fatal due to any cause, due to any reason. It might be fatal. So such as the complications of diabetes, all the florid macrovascular complications are present. 10 years he was hovering around 9 to 12. Still the creatinine is holding good. The only thing is what was remaining is the kidneys. Rest everything is damaged. So this patient was on twice daily of NPH. So twice daily NPH and regular insulin of 15, 15 and 10 in the day with glimepiride 4 milligram with voglibose of 0.3 milligram twice a day. So now I'm not going deep into the elaborate management for other aspects, just the glucose control. So other aspects, every field of medicine is going to get involved. So glucose control regarding this individual, just stop all the voglibose, oral antibiotic agents, whatever is going on. Whenever a patient is sick, try to stop all the oral antidiabetic agents. That is the key. That is the key. So stick with, maybe if you want to add an oral antibiotic agent, just stick with gliptins. If there is no contraindication, say there is no pancreas issue, just stick with gliptins and shift over to only insulin. So that is the key here. So and don't go for premixed insulins. There's no contraindication per se. Always try to stick on to split mix insulin or basal plus or basal bolus insulin for the very sake of titration. It's very, very difficult to titrate with premixed insulin. There may be a tendency, since it's very easy. So, but you can never titrate. You will not be knowing what you are doing with that patient. So this patient was started on ultra long acting analog insulin plus 3 times of glulisine. So what the name is not an issue. The main issue is we are starting with the basal bolus insulin plus gliptin, linagliptin. Patient lost. Look at patient shifted to North America after recovery. There she developed papillary necrosis. There in the critical IV anti. She herself volunteered to get readmitted because the cost of care in Canada was for citizenship, whatever. She need to pay. Paid around
rupees. So she admitted here. Actually, she admitted here purposely on purpose. Then she realized the quality of care, the cost-effective care we give here. She herself admitted. Then we started again titration and treating complication. So here somehow the patient had a HbA1c of 8.1, but on admission it was 8.1. How come they came down? Because of loss aspect. We might think glucose will be elevated because of loss of weight in critical care. Many patients lose weight, lose fat, lose visceral fat. Their insulin resistance will go down. Many patients, if you check, many patients will admit for 1 month in the hospital. If you check HbA1c after 1 month, spontaneously it will come down because of poor nutrition, visceral fat mass. So another patient. So look at the sugars. Fasting very high, post breakfast very high, post lunch was low, post dinner was low. So what do you mean by this? So if you look at the 4 point, this is another case, 4-point glucose profile. If you see each and every point, it is different. Fasting is high. I hope all are able to see the slides. Okay, fasting is 245. Post breakfast is 430. Whereas post lunch is only 90 for this individual. Post dinner is 214. So what does it imply? So one fasting sugar is not representative of the entire 24-hour glucose profile. So you do a BD monitoring, right? You are not going to achieve anything with that. So look at the post breakfast here. It is 430. Look at the post lunch, which is your usual BD monitoring. So for this individual, if you have been doing BD monitoring, you will see fasting of 245. As usually, give you a tripod of 10 units or a mixture of 10 units. Then you'll check a evening sugar. It is 90. Happily, you will say the sugars are well under control. That's all. Not at all case. It is vice versa. Post breakfast 430, you are going to miss the point. So post breakfast hyperglycemia, even if the patient does not take food, 11 a.m. to 12 p.m. hyperglycemia is the highest glucose level for any individual. Why? Can anyone say? Well, because the reason is cortisol excess. Cortisol peaks in the morning. So you get maximum insulin resistance in the morning only. So if you want to target a glucose level, treat a glucose level, treat the 11 a.m. or a pre-lunch hyperglycemia. So there is no point in just doing BD monitoring. You are not going to treat anything. So this patient required a short-acting insulin of 46. In case if you have been giving just Mixtar, say 20 units, seeing that value of 245, again you are not going to achieve anything. Mixtar contains only, say out of 20 units, 6 units of short-acting insulin only. How come that post burst will? So look at this here. That individual units morning. You are not going to achieve control. Monitor either 3 times a day, or if you want to monitor 2 times a day, monitor fasting and post breakfast or on NPO 7 or 12 p.m. glucose. This is the glucose you need to. So this must have been and but and actually the in hospital.
So this case I'll skip. So a 60-year-old male, type 2 diabetic, peripheral disease, DKMT, another common scenario, creatinine of 2.1, probably chronic kidney disease. But this individual also had an element of non-diabetic kidney disease. So the crux is not all kidney disease are due to diabetes. They will also be having a non-diabetic component simply because we are living in the second most populous country in the world. You will be having all the disorders. Never estimate this is only diabetic nephropathy. Patient will be having concomitant other disorders also. So you have to treat both. You have to treat both. So this patient was started on whatever non-diabetic kidney disease, immunosuppression, prednisolone. What is going to happen? Sky high sugar values. Again, don't check just fasting. Whenever you're giving glucocorticoids in the morning, you will get severe low fasting glucose. So don't get cheated by normal fasting glucose levels. The post dinner and the post lunch glucose will be 500. The fasting glucose will be 101. So you won't even be treating the patient for hyperglycemia. So you have to supposed to treat all the three post meal glucose simply because of the TF of the glucocorticoids. It will act in such a way, it will start escalating as time passes. It will cause severe insulin resistance. Only post meal hyperglycemia will escalate. So you have to treat accordingly. This patient required only very, very small basal because of the low fasting glucose. Whereas look at the short acting insulins. 28 units in the morning, 42 units in the lunch, 46 units in the dinner. This is just one example. So many patients are there. So literally many patients on glucocorticoids, literally every field of medicine, every field of surgery, almost any patient you take will be on glucocorticoids, hematology, oncology, neurosurgery, neurology, nephrology, any field you take. Medicine, pulmonology, any field you take, they'll be on glucocorticoids, pediatrics also. So you have to treat the post-meal part specifically. So only gliptins are allowed. Other drugs try to refrain. And regarding metformin, whenever a patient, there is an escalation of creatinine to say 1.3 to 1.4, so avoid even 500 milligram of metformin. Theoretically, you might be wondering, patient is stable, it is given in the textbook, KDIGO guidelines, those are the things. So how long does it take for the creatinine to jump from 1.3 to 1.9, you think? How long does it take? One episode of diarrhea, one episode of vomiting will escalate the creatinine, right? One episode of diarrhea or vomiting. So that is enough. And that metformin will be ominous. Again, it will escalate the creatinine level. So just avoid creatinine totally. So use only gliptins, and even SGLT inhibitors also. Be wary. The patient is very stable, no lower urinary symptoms, then use SGLT inhibitors with caution, and you have to alert the patient also every time. If they get any issues, just stop the SGLT inhibitor. So they can use sulfonylureas, they can use gliptins. So steroid was tapered. So that is according to the nephrologist. That's as physicians and diabetologists, we are not going to interfere. So we are not supposed to interfere. That the treating physician for the primary kidney pathology, they will take care of it. We have to titrate accordingly. So this case, HbA1c was 12, a 50-year-old female, premix of 30-70, BD twice a day with recurrent hypoglycemias, simply because Indians have predominant post-meal hyperglycemia than fasting hyperglycemia. No question about that. Indians 80 to 90% post-meal hyperglycemia. So 30-70 literally will be having a very less role. If you observe, very less role. We might need a 70-30 insulin, which is not in vogue across the globe. So what I mean by 30-70 is basically 30 is a short-acting component, 70 is a long-acting component. So that suits mainly for type 2 diabetes mellitus in the initial phases only. Later you need basal bolus or basal plus for titration or split mix insulin. So this individual required split mix insulins with corresponding titration. So if you see, we kept on titrating for this individual and we landed like regular insulin of 60 units in the morning. 60 units of short-acting insulin in the morning. So that much of post-breakfast hyperglycemia. Then she started developing hypoglycemia. So that is a small good thing. Then we can down titrate the insulin level. So then we started adding all the existing medications. So try to utilize all the medications when the renal functions are good: metformin, thiazolidinediones, pioglitazone, gliptins, and flosins, SGLT inhibitors. So this individual post CABG HbA1c of 13, again was on mixed insulins, recurrent hypoglycemias, post-operative, again recurrent hypoglycemias and early morning hypoglycemias. So postprandial was 400 plus. See, look at the morning short-acting insulin required for this individual, around 50 units in the morning. So we might be wondering where all these patients were. We were never using all these aids. This is in our own hospital. So these patients, most of the patients will be needing lot of short-acting insulin in the morning. If you really check the post-breakfast hyperglycemia, you will start wondering how to control it. Then we need a post-breakfast controlling medication in the morning. So if you see this CGM, literally it's sky high, right? All the glucose level is sky high in this individual. So it's basically a 9-month-old child. Dr. Shobi will be discussing in detail about these individuals. Just this case also came across us, 9-month-old child, HbA1c of 9. So basically diabetes mellitus. To beat phenotype, whether type 1 or any other genetic diabetes variant, we have to see. So genetic testing awaited for neonatal diabetes. So this individual, whatever it may be the cause. As of now, you have to control the glucose level to avoid ketoacidosis, which may be fatal in this in this child, young child. So degludec just 3 units and short acting of 232. So in pediatric age group, very young individuals, the most important thing is not exact glucose titration. Just give some insulin to avoid DKA and complications. So this individual, A1C of 7.2, postprandial was 423, premixed insulins, again it was quite high, and lot of insulin required to control the glucose level. Why? You might see HbA1c of 7, but the glucose started rising. We started insulin. In spite of giving tons of insulin, glargine of 40, regular insulin of 78, 46, 34, still the patient's glucose level was not under control. Why? The insulin technique. The patient was giving intradermally. So insulin technique plays a role. We ourselves have to teach the patient once. For that, we ourselves have to be confident and we should know what is the correct technique, where to administer. Don't take it for granted that all staff will be knowing this. Don't take it for granted. We know it. Every time we have to learn it, we have to teach the patient. And if the patient says, we might also hear this patient will say, no, I know. I have given insulin to my father, mother, grandfather. I know for the past 12 years I'm giving it. No, don't take it for granted. That individual will suffer from this. Just a technique, barely 2 minutes you need to teach. That's all. It's subcutaneous. Again, common error. A 11-year-old girl was admitted 7 to 8 times. They said he was compliant, regular SLBG monitoring, still DKA, multiple episodes of DKA and high HbA1c. They were stored in freezer. They were stored in the freezer rather than the fridge refrigerator door. So again, on common error, onus on the physician. We have to teach the patient and the patient attenders. We have to have a diabetes educated team. So it should be stored at 2 to 8 degrees Celsius, not sub-zero, not freezing temperatures. So I think I'll stop here because of lack of time. So another last point, another most important thing, the units per ml. If you are using, say, many a times you'll be using Apidra, Lispart, other types of vials. So most important, you have to use the 100 per ml syringe. The simple teaching is every time the patient or the staff has to administer, you have to see the vial and the syringe. Both should have the same per ml units. If the vial contains 40 per ml, the syringe also should contain 40 per ml. The vial contains 100 per ml, the syringe also should contain 100 per ml. So again, don't take it for granted. The staff will be knowing every time you have to check. Ask them to give the vial as well as the syringe. You can find out. This error, in spite of me being here for 5 years and teaching so many times, again the error occurs. Every time we need to check at least once a week or twice a week. So I'll stop it here. Any doubts? I can take it now. Any doubts regarding diabetes management? I know it's huge. It takes years and years. Just common, whatever challenges you have come across, anything which strikes, please ask. It may be very basic. All these things are basic only. Daily, I also learn. Daily, it's a challenge. Every patient is a challenge. Fine. So
Thank you, Dr. Krishna Shankar.
the mic and the podium to Dr. Shobi Anandhi. Thank you very much.
Hello, am I audible? Hello, am I audible? Hello.
Yes, sir, you are audible, sir.
Yeah. Thank you, Dr. Krishna Shankar. And any questions, I think we can have it at the end of the session. And now I call upon Dr. V. Shobi Anandhi to deliver her lecture.
A very good evening to one and all. And I'll be discussing about diabetes in children. So without wasting any time, I will go ahead. At the beginning, I would like to thank Dean Sir and the hospital management for giving me this opportunity. And everybody knows about diabetes. Diabetes needs no introduction. It is a common chronic metabolic disease which is characterized by hyperglycemia. And there are different forms of diabetes. Type 2 diabetes is the most common across all age groups. Type 1 accounts for only 5 to 10% of the total diabetes cases. And we have rare forms like neonatal diabetes or maturity onset diabetes of the young, or diabetes secondary to pancreatic disorders, endocrine disorders, drugs. So the important thing to remember is that the incidence of type 1 and type 2 diabetes among young people less than 20 years of age is gradually increasing over the last 2 decades. So this is very important. So we should have a high index of suspicion for diagnosis and management of these cases. Now let's restrict ourselves to only diabetes in children. So type 1 diabetes is the most common type of diabetes, accounts for more than 90% of the cases. In India, the incidence is 4.9 cases per 1 lakh per year, and at present we have around 95,000 children of type 1 diabetes less than 14 years. The incidence of type 2 diabetes is also increasing. The pathophysiology is the same like those of adults. So for type 1, it is basically a genetic underlying background, and there is an environmental trigger, which is usually a viral infection, which causes autoimmune insulitis, beta cell destruction, and insulin deficiency. For type 2, it is obesity because of sedentary lifestyle, excessive calorie intake, and low physical activity, which causes peripheral insulin resistance, and that causes beta cell dysfunction and diabetes. So pathophysiology is the same. The only thing is the management and diagnosis, it should be such that it is addressed to the unique psychological needs and challenges of growing children. So that is what I'm going to discuss today. So in the beginning, I'll just start with a case. This is one of our patients from our hospital. This child is a 8-month-old female child who presented with rapid breathing, abdomen pain, and multiple episodes of vomiting for 1 day. Was treated elsewhere thinking it's a respiratory tract viral infection with nebulizations, multiple IV fluid boluses for dehydration, and other supportive treatment for the gastrointestinal complaints. However, when routine investigations were done, the child was found to have high blood glucose levels with severe metabolic acidosis, giving a diagnosis of DKA. The child was then referred for further management. She was treated as per the ISPAD diabetic ketoacidosis management protocol. Correction of electrolyte abnormalities were done. The child was then gradually shifted over to multiple daily subcutaneous injections in the form of a basal bolus regimen. And now, after 3 years of diagnosis, the child is growing well, maintaining her blood glucose and HbA1c levels in fairly normal range. She attends full-time school. She takes her pre-lunch insulin dose at school with the help of her teacher, uses a CGM to monitor her blood glucose levels, and is actively involved in her diabetes care. So let's discuss what are the challenges that we face as doctors when we diagnose or manage children with diabetes. So we all know the classical signs of diabetes, isn't it? Polyuria, polydipsia, right? So it's actually the 5 T's: polydipsia, polyuria, tiredness, weight loss, and finally a blood test. But children do not show these features all the time. And even if they show, there is a high chance of it being missed, or sometimes attributed to some other cause. They say child is drinking water, that is why the child is passing urine. So often the parents as well as the treating doctors tend to miss this as the clue for diagnosis. So what happens is these children, as they are having a smaller weight, they are more prone to dehydration, and they usually present with frank decay. Now, when a child presents with decay in the ER, decay is never in the list of differential diagnosis. It is always lower down somewhere. So we always think of common illness. So if the child comes with abdomen pain, vomiting, we think of gastroenteritis, some acute abdomen. If the child is having breathing difficulty, we think of bronchiolitis, asthma. If the child is having altered sensorium, the first thing that comes to our mind is septicemia, meningitis. So it is often missed, and that is quite common. We have seen it very often. So we should have a high index of suspicion to diagnose these children. Once we diagnose a case of type 1 diabetes, then the challenges come in the form of therapy. So what happens is, here the parent takes the primary responsibility to treat the child. Isn't it? The child is not responsible, it's the parents. They have to learn how to give insulin, how to check the blood glucose, how to change the diet. Everything is against the wish of the child. So sometimes it's a very difficult situation. Both the parents and the children need a lot of psychological support, and this is provided with the help of diabetes education. The insulin doses which we use for kids is very small. So 2 units, 3 unit, 1 unit, and sometimes in infants, we need to even dilute it with normal saline so that we are able to give the appropriate dose. Even 0.5 units extra could cause hypoglycemia. So nowadays, however, we have these new pens which actually can deliver 0.5 units. We have the insulin pumps which help us to deliver small units of insulin to the child. The dose of insulin depends upon the diet. Now, can you ever predict what a 2-year-old or a 3-year-old is going to eat in the next meal? It's very difficult. So parents find it very difficult to understand how much insulin the child should receive. So what we usually do is we ask the parents to first feed the child and then give a rapid acting insulin immediately after the feed, depending on how much the child has eaten. So these are challenges which are very unique to the pediatric population. Monitoring of blood glucose is very important because these children have very erratic eating patterns, physical activity. You don't know when the child is having high blood glucose or low blood glucose. However, with the use of CGM, which is continuous glucose monitoring devices, life has become a bit easier. Monitoring of ketones. We explain and teach the parents to monitor ketones when the child is sick or when the child is having high blood glucose levels. Management of type 1 diabetes in school itself is a separate topic. So actually the parents are encouraged to share the diagnosis with few of the teachers, with few of the classmates, so that they can help the child when needed. The child is encouraged to take his insulin dose in school with the help of a teacher or a school nurse. And many children are actually able to do the same. Nutrition. Children are growing. They need adequate nutrition for growth and development. Now, what happens in adults is we easily can prescribe a diabetic diet, but that can't be done in children. In children, we encourage parents to give a variety of foods at consistent times and in consistent amounts so that we are able to adjust the doses of insulin accordingly. In an older child, however, you can have a structured meal plan, you can have exchange ratios, you can do carb counting to ensure that the child receives adequate nutrition. Children are inherently very active, so you can't predict that the child is going to play now. And whenever there is activity, the chances of the blood glucose levels dropping is high. But that's not a reason why we should stop the child from being active. So children are encouraged to be active, but when the child plays for a long time, for example, for more than an hour or so, we encourage parents to give a snack, or you ask them to monitor the blood glucose and take actions accordingly. Now, we all know the classical signs and symptoms of hypoglycemia, but children do not exhibit or show these symptoms. In a young child, it could be just a temper tantrum or irritability or excessive cry, which could indicate that the child is hypoglycemic. And if it is ignored, these children could then develop a severe episode, can become unconscious, or can have seizures. So parents are taught how to identify these episodes and treat accordingly. Another important thing which differentiates an hypoglycemic episode from an adult is that children have developing brains, and repeated episodes or very severe episodes of hypoglycemia can cause insult to the developing brain and can cause cognitive impairment. So that is also important. Finally, monitoring of HbA1c and associated conditions like thyroid, celiac disease, or complications is important. But at the same time, we need to monitor the growth and development of the child. So these are all important things which have to be taken into account when we manage a child with type 1 diabetes. Sick day. Children often fall ill, right? So every month they have a viral infection, and whenever they get an infection, they have a high chances of fluctuating blood glucose levels. So the mnemonic sick is used to teach the parents how to manage a sick child. S stands for sugar. So they need to monitor the blood glucose levels and adjust the doses of insulin. I stands for insulin. Insulin should not be stopped. Even if the child doesn't eat, they have to receive a minimal dose of insulin to prevent ketoacidosis. C stands for carbs. If the child doesn't eat solid foods, the child is encouraged to take more fluids. At least, sugary stuff, if sugary fluids, if the blood glucose levels are low, to ensure that the child takes adequate carbohydrates and supplement with insulin. And the last K stands for ketones, where the parents are asked to check for ketone levels to identify ketoacidosis. The second case history is about a 2-month-old male child who was born of second-degree consanguineous marriage, was an IUGR at birth, 2.1 kgs, poor weight gain since birth, and was detected to be hyperglycemic at 3 weeks of age. The blood glucose levels were between 300 to 400, urine ketones were negative, insulin and C-peptide levels were low. This child was treated with insulin infusion and oral feeds. Actually, they had called and based on our advice, they were managing the sugars and then referred. The child was started on subcutaneous insulin injections, both rapid-acting analogs Lispro and injection glargine as a basal dose. Now, regular glucose monitoring was performed, and at follow-up, the child's weight improved. So as was discussed in the previous topic, the genetic test for neonatal diabetes is the first step for the diagnosis of the cause of neonatal diabetes. So KCNG11, ABCC8 and INS genes turned out to be negative, and at around 2 months, the child was not needing the rapid-acting doses. So in between, we were giving them rapid-acting insulin when the blood glucose was more than 250. The child was not needing those doses at all. And by 3 months, the child even did not require the basal dose. Now at 1 year, the child is absolutely normal with normal blood glucose levels. This is nothing but a case of transient neonatal diabetes. Neonatal diabetes is the onset of diabetes in the first 6 months of life due to a mutation in a gene which affects the pancreatic beta cell function. If you go back to our physiology, this is a pancreatic beta cell which has glucose entering through the GLUT2 receptor, which is metabolized to release ATP, which acts on the ATP sensitive potassium channel and closes the channel. Channel is closed, depolarization, which causes influx of calcium via the voltage gated calcium channels, and that causes release of insulin. So when we have a defect in this gene, then this is an activating mutation, so the channel remains open. So depolarization does not take place and insulin is not released. Now, why is this so important? Because when you have a defect in this gene and you can treat this child with sulfonylureas. What is the mechanism of action of sulfonylureas? It is to act on this receptor and act on that channel and close the channel. So these children can be treated with sulfonylurea, and that is really very life-changing because you do not take insulin. So that is why the genetic test is the first step in the diagnosis for neonatal diabetes. Depending upon it, we have different types. I'm not going to go into the details. Our patient did not have any of these genes positive, so was destined to receive insulin, but was lucky enough to have a transient form of diabetes. However, these transient cases tend to get relapsed again at adolescence. So this has been explained to the parents. The last case, this is a 12-year-old child who presented with polyuria, polydipsia, and weight loss of 7 kgs in the last 3 months, blood glucose levels in 300s, history of type 2 diabetes in his grandparents. If you look at his growth chart, his weight was on the 97th centile, his height just I think on the 75th centile, and BMI was way above the red line. The child is obese. And if you look at his neck and his flexures, he had acanthosis nigricans. This is a marker of insulin resistance. His investigation showed him HbA1c of 11.4, fasting plasma glucose of 212, insulin of 14. So it means insulin was there, it was not deficient. C-peptide was now 4.3, urine ketones was 2+, thyroids were normal. They refused for an anti-GAD antibody test. So clear-cut diagnosis was new onset diabetes, but we are not sure whether it is type 1 or type 2. The child is obese with features of insulin resistance. There are ketones present. Insulin C-peptide is positive, so it's a mixed picture. So we often see these cases nowadays. The idea is to start with insulin first and just wait to see how the child progresses. So child was started on basal bolus regimen with regular blood glucose monitoring, lifestyle changes in diet and physical activity. Insulin requirement at 3 months of age was only 3 months of diagnosis was only 0.5 unit per kg per day, and all blood glucose levels were less than 150. So the child continues to be under follow-up, and if we find that the child is getting better, maybe we will bring down the insulin and introduce metformin. So just a few words about pediatric type 2 diabetes. The incidence is increasing because of obesity. And if you see, this is what we're classically taught. Type 1 is insulin dependent, type 2 is non-insulin dependent, right? This is because of autoimmune cause, this is because of obesity. But actually, if you see clinically, the differences is not always very straightforward, and in many cases lot of combinations are seen. So the problems at the time of pediatric type 2 diabetes mellitus diagnosis is basically that because obesity is increasing, 30% of our type 1 diabetic patients are also obese. So you can't say this child is obese, so this child is having type 2 diabetes. Second, obesity, diabetes is present in almost all the families. So positive family history of type 2 diabetes is not going to give us any clue. Third, type 2 diabetes mellitus in pediatric age group can present with ketosis. So you can't say ketosis is there, therefore it is type 1. And insulin C-peptide levels are not always reliable. In type 1 diabetes, honeymoon phase, residual insulin pancreatic function, you may have insulin and C-peptide positive. And in type 2, because of glucotoxicity and lipotoxicity, beta cell dysfunction, the levels may be less. So again, that cannot be used. But one clue is that if a child has high levels of C-peptide around 1 or 1.5 years after diagnosis, it is more likely to be type 2. Insulin resistance acanthosis is present in both type 1 and type 2. Autoantibodies definitely help, but even in some type 2 diabetic patients, I think in some study they say around 5 to 35% of type 2 pediatric diabetic patients may have antibody positive. Again, it is a query. It is only by regular follow-up you are able to judge and identify whether this child is type 1 or type 2. So the take-home message is that when a child receives a diagnosis of diabetes, it's definitely the start of a long journey with ups and downs for the child and the family. But most of the children are able to successfully make their way through the chronic disease, and they learn to cope up and adjust to their diabetes. So diabetes education is the key, and that is what we stress upon every time at every visit. Success depends on a well-functioning and fully informed family, and available and experienced diabetes healthcare team, and support from the family, friends, and school. Thank you.
Thank you, Shobi. Any questions from the audience to Dr.
Do you
Krishna
have any doubts?
and Dr. Shobi? Any questions are welcome.
Any doubts?
Murali?
Yes, sir.
Murali, am I audible?
You are audible, sir. I think you have not received any questions from audience sites, online audience sites, sir.
No questions, sir. Murali, am I audible?
Sir, கேட்க மாட்டேங்குது. இங்க தான் இருக்குங்க சார் பேசுறது.
Murali?
You're audible, sir.
Can you hear me?
Yes, sir. Yes, sir.
No, if there are no questions, then I thank Dr. G. Krishna Shankar and Dr. V. Shobi Anandhi for acceding to our invitation and coming here and giving a wonderful lecture, both of you. On behalf of the management, I thank both the doctors.
Thank you, sir.
And I would like to thank the audience, consultants, our postgraduates, doctors from Ramakrishna Hospital, and from outside, from the city of Coimbatore, and also our Allied Health Institute students who have come to attend the lectures. I thank all of you once again. Thank you.
யாருக்கு doubts இருக்குது? Anybody having doubts here? No doubts. I think